So welcome to our CCM today. My name is Annette. If you don't know me, P2Y4. Special thanks to the team, Dr. Snupane, D'Souza, Beda, Eden, Kim, and Dr. Behrens. Our EMCCM conference today is about a 30-year-old male who was the discussion. I will briefly start with the severity spectrum of pulmonary emboly very briefly, remind you of the spiral of death, and then I'll address in more detail the management. The severity of acute PE, there's three groups: a low risk, intermediate risk or submassive, and high risk, massive. Our patient was presumed to have a massive PE. The AHA definition basically says acute PE with sustained hypertension, SPP less than 90 for at least 15 minutes, or requiring inotropic support, not due another cause than PE, or pulselessness, or persistent profound bradycardia. Massive PE with shock has about 30-day mortality, 16 to 5%, and if there is cardiac arrest, it goes up to 60%. This is just one of many algorithms for PE that in the end look very similar when it comes to the massive PE. So basically, if the patient arrives in suspected PE, is hemodynamically unstable, the first thing that is echo. If there's a PE confirmed, then thrombolysis or other definitive treatments are being started. If the PE is likely and the patient is stable enough, he goes to CTA. If not stable enough, reverts back to the first branch and thrombolysis or other definitive. Now, this is the hemodynamic spiral of death. From the case, you know that we're pretty much already at the end. I'm going to take a stab at walking us through this infamous spiral. So basically, PE initiates the death spiral with an acute increase in pulmonary vascular resistance due to the physical obstruction, also due to hypoxia and hypercarbia, and some passages that increase the pulmonary vascular resistance. This means that the right ventricular afterload increases. The right ventricle is pretty thin-walled and filled with a low-pressure circulation. So with increased afterload, the right ventricle stroke volume goes down, and the right ventricle will dilate and wall tension will increase. This results for the right ventricle in worsening coronary perfusion because versus the left ventricle that's produced during diastole, the right ventricle is produced during diastole, but mostly during systole. Another result from this is a myocardial inflammation, overall increased output demand for the right ventricle, and subsequently right ventricle ischemia. The next step is a decrease in right ventricular contractility, right ventricular output, and subsequently also left ventricular preload. What makes it worse is that the interventricular septum often falls into the left ventricle, which also reduces the cardiac. This further worsens the coronary perfusion and makes the cycle even worse, increases the right ventricular ischemia. The final result from this spiral is obstructive shock death. Now, management of massive PE. The literature on massive PE focuses a lot on how to deal with the clot, and a little bit less attention is paid on the other aspects of management. So we recently had a great CCM lecture on thrombolytics, and I'm not going to focus on that. And after this lecture, we will have an external lecture who will tell us a lot about endovascular. So for the next few minutes, I'm just going to lightly touch on ways of dealing with the clot, and then I'll focus a little more on the other aspects of management. Patients with massive. Generally, patients with massive PE often decompensate very rapidly. They might look fine 1 minute and might be floating. the reduction in pulmonary vascular resistance. Those are basically the forms of definitive treatment. The systemic thrombolytics are highly effective and for cases of massive PE also widely accepted. They can be applied very fast and are widely available. The other definitive treatments like the catheter-directed thrombolytics, endovascular embolectomy, surgical embolectomy, much longer in onset and are not available. And there's one point I'm actually not mentioning on a page. That's the pulmonary vasodilators. I just want to touch on it in one sentence. There is, in some cases, a report of use of epoprostenol or inhaled nitric oxide. I've never seen that used. Has anyone used it and wants to say a sentence? How it worked out? No, I don't think we have nitric oxide here, even though State invented it. Yeah, there's not much data. There's like a case study with 4 patients who improved significantly in a very short time after inhaled nitric oxide. I also read about alternatives, for example, inhaled milrinone, nitroglycerin, that can be helpful. But not to forget that it is hypoxia that increases the pulmonary vascular resistance and a very strong pulmonary response. So in patients with decompensated right ventricular failure, a higher concentration of oxygen might be indicated to reduce pulmonary vascular resistance. So this is how systemic thrombolytics work. Just a reminder, you have the fibrinolytic agent that acts as tissue plasminogen activator, and they convert plasminogen to the proteolytic enzyme plasmin and then lysis. Everyone. Systemic thrombolytics, generally indication is definitely given in a case of passive PE. There are absolute and relative contraindications that we're aware of. However, in a situation like ours, there might not really be any absolute contraindications towards you given the situation. The main concern about using systemic thrombolytics is the risk of cranial bleed. Studies mostly extrapolate from acute INCVA data. Generally, these patients in INCVA are probably more likely to bleed, and is often already on other anticoagulants, and CVAs have already an acutely injured brain. So generally, people with PE should possibly be less likely to bleed. Couple studies say that the risk of intracranial hemorrhage for CVA patients is around 2 to 7%, for PE is about 1.5%. Approximately. The following interventions that I'm just going to touch on very quickly are not happening in the ED. Catheter-directed thrombolysis. This is an alternative to systemic thrombolysis used for patients who have contraindications to systemic thrombolysis or where systemic thrombolysis failed. And as said before, our next speaker is Severity. Then we have endovascular embolectomy. And again, our next speaker is going to talk about this. And finally, surgical embolectomy. That is become a little bit more rare, but recently there was some advancement and the cross-clumping of the aorta and the rest of the heart could be avoided. So traditionally, surgical embolectomy was reserved for patients with cardiopulmonary resuscitation, and also for patients with contraindications of inadequate response to thrombolysis, patients with patent foramen ovale, or as in our case, relevant for patients with right heart thrombi of blood. Any comments on that section? Anyone? Critical care interventions. I'm going to touch on the maintenance of systemic perfusion and cardiac output, and I'm going to talk through possibilities of a hemodynamic neutral intubation. First, the maintenance of systemic perfusion and cardiac output. First of all, optimization of preload and restoration of systemic pressure. optimization of preload. So, reflexively, our response to hypotension in undifferentiated shock is to put in 2 IVs and start with fluids running. And that's somewhat also what happened a little bit in this situation. The patient received about 1.5 liters of IV fluids from the start. So, but the problem is in obstructive shock, specifically in massive P, that can worsen the situation. It can increase the right wall tension, right ventricular dilatation. So there's a big difference. Do you have a right ventricular infarct or do you actually have? So there was still one small study recently that looked into increase in cardiac index in massive P with fluid, and they found that up to 500 cc's, they did find some increase in cardiac output, but above that is definitely not. An exception might be if the patient is overall very dehydrated. There was some information that maybe another 250 cc, but in between 500 and 1,000 cc's was also the recommendation was to keep the ultrasound bedside and keep checking if there were any signs of worsening situation when the patient was getting into. So next is our restoration of systemic pressure. The systemic pressure needs to be restored to maintain the end organ perfusion and the coronary perfusion, particularly prevent this ischemic damage to the right ventricle, because that would push us into that spiral of death that we. So the goal is to keep the systemic pressure higher than the pulmonary pressure and to avoid hypoperfusive right ventricle. One remark that I saw a lot was place an A-line very early, that you can modulate the blood pressure very directly. However, whatever line you place in a patient with massive PE should be done by someone very experienced because the person likes thrombolysis. And you want to avoid any damage to an artery or any place a central line, any other vessels. So we just learned that you don't want to drown the patient in IV fluids when they have a massive PE. So the second choice would then be vasopressors. And that's pretty much the big thing. Start vasopressors early, and starting it early for us normally means early. There's not a big body of systemic reviews about which pressures to use and why. It's more anecdotally and often provider dependent. So I looked into which pressors would be best increasing the systemic vascular pressure, pulmonary vascular pressure. And I have a list. Is there anyone here who has like a very preferred pressor that they want to share and why? Any one of the attendees maybe?
Probably just use for update, not a specific reason other than just
NORP, two votes for NORP. Okay. So basically what we want is we want to increase the systemic vascular pressure more than pulmonary vascular pressure. Also, this is a good agent. So starting with phenylephrine, that basically only has alpha-1, seems to increase the systemic and the pulmonary pressure pretty much in the same. So not the first choice. Also has an
You said phenylephrine?
You
said
phenylephrine. Yeah. Then vasopressin seems to increase the systemic vascular pressure, but not so much the pulmonary vascular pressure. So very favorable ratio there. And there's also some evidence that vasopressin may act as a vasopressin. Then our norepinephrine. Some people love it a lot, some people love it a little less, but it has alpha-1, beta-1. It increases the systemic vascular resistance more than the pulmonary vascular resistance, particularly at low doses. It has a positive inotropic effect. There are some voices that say that if you go higher in the dosage, it might flip and might increase the pulmonary vascular resistance more. And then there's epinephrine, has alpha-1, beta-1, and beta-2. For low doses, anecdotally, there is a very good ratio between systemic vascular resistance and pulmonary vascular resistance, and it's a universal. So that's pretty much the most popular ones that I found. On review, there's also glutamine, milrinone, not so popular engine. What we did here was we started norepinephrine and then we added basic acid for patient. Any thoughts on this pressor combination? Just a few thoughts about how you intubate a patient with massive. So basically, don't. Try not to. Because intubating the patient can result in hemodynamic collapse. The agents can cause vasodilation and worsen the hypotension. The decrease in ventilation oxygenation peri-intubation can increase the pulmonary vascular resistance. The increase in intrathoracic pressure with transition from negative to positive pressure due to mechanical ventilation can reduce the venous return and can lead to a further drop, right? So generally try to avoid intubation. Go quickly to final treatment of respiratory failure by starting thrombolysis. That often has a very quick effect and maybe can help to avoid intubation at all, or try something like high flow nasal cannula with very high oxygen to reduce pulmonary vasal restriction. But if you must intubate, I'm first giving you a shameless plug for ultrasound. Ideally, every patient in obstructive shock or intubate should get a swab. A rush exam is normally the way to go. So you can identify the potential causes. You can identify if there's a pneumothorax, if there's a pericardial tamponade, or you can identify other signs for massive. For the rush, just as a reminder, you use the HIMAP acronym. You go to the heart, you do parasternal long, and then four-chamber echo. That already shows you, in our situation, that there is a indication for massive PE. Then you go to IVC view. Our situation, you see a dilated IVC. You might even see a clot in transit, which they saw in the second zone. The general route, you do the Morrison splenorenal, then you go abdominal, and then you check the pneumothorax. The first few steps would have already given us a lot of information, and the two sonos were done to guide treatment in our situation. How does POCUS look like for massive PE in more detail? We do an echo, we see a right ventricular dilatation, we see a right ventricular systolic dysfunction, we see the famous D sign, dilated IVC, and a thrombus, possibly a clot in transit. So this is an image for the right ventricular dilatation. You see that the right to left basal diameter is, which is normally 1 to 3 to 1 to 2, is changed to a larger right ventricle. There could be tricuspid regurgitation, and normally you see that the right ventricle is pretty thin wall, because if you see a thick wall, the McDonald sign that Adrian mentioned before is an echographic finding in patients with acute PE that shows some regional wall motion abnormalities in the right ventricle, and at the same time a sparing of the right ventricular. So I really wish I could show you.
You can click it now. Yeah.
Okay. It's 27. You see how the apex is still moving, the right ventricle, but you see some inertia of the ventricle. Great. So there are three possible mechanisms for this observation. So one is that The right ventricular apex basically moves because the left ventricle is still moving and it's being pulled by the left. The second is that the increased pressure might reshape the right ventricle into more a spherical shape that leads to this oscillation. And the third is that there is some localized ischemia of the right ventricular tree wall, and that is the reason for this paradox. The McConnell sign was found to be 77% sensitive and 90% specific. However, caveat in that study, patients' right ventricular are infarct. There's also TAPSY. I'm not going to talk about TAPSY right now because that's pretty high effort and a situation Russian patient. Here is the D side. Self-explanatory. You see how the right ventricle is dilated and goes into the left ventricle. And you can see a plethoric IVC that's generally over 2.5 centimeters diameter with no inspiratory collapse. And here, these images I bought in transit. So basically, if we go ahead and intubate the patient, same as before, start presses early. We cannot give fluids, we already discussed that. We want to start the intubation with a reasonable blood pressure. So ideally, have the presses running even before we intubate, or if we don't have that, have a push dose of presses ready. So generally, the popular push dose pressor was epinephrine when I looked around. Anyone here in the audience has any particular popular push dose pressor?
I use that.
Epi, awesome. I found a quick recipe how to make it. Take a flush, waste 1 cc, draw 1 cc of full dose epi, and then you have a concentration of 10 mics per milliliter, and you can give 0.5 to 2 every 2 to 5. Next one, again, place an A-line early that you will notice immediately if there's any hypertensive vessels. For that, again, it's not a junior line. Have someone do it where it doesn't cause to the artery. And now choose cardiostable induction agents. So these are our usual suspects. So which one of those would you choose to intubate a patient with massive? Junior?
Ketamine. Is it ketamine?
Ketamine, awesome. Why?
Does it mean at most it will increase blood pressure versus like hypotension?
Mm-hmm. Good. Is there another one you would like besides the ketamine? Mm-hmm. Etomidate, yeah, also does not make the patient hypotensive. Exactly. So this table is way too busy, but it basically shows that fentanyl, propofol, and also midazolam have hypertension as a negative side effect. So we choose those cardiostable induction agents, and now we have to also adjust the dosing to our situation. So what is interesting is for intubating a patient with massive PE, it is advised to go low on the sedatives and higher. For example, if we use ketamine, normally we would have 1 to 2 milligrams per peg, but we're going to halve that and start first with 0.5. But it makes sense to have another dose in the pocket in case you need to add. Then for the paralysis, we can use SACs or what I found was recommended was rocuronium. Normally the downside there is that it takes a little bit longer onset, but if you increase the dosage, the onset becomes quicker. So I found that if you increase it to about 1.6 milligrams per kg, you have a similarly fast onset as saxenopholine, and you have a little bit longer safe after. So this combination, the ketamine and Stacia.
I was just going to say, I'm curious what other people think about doing a half dose of ketamine as your sedative then using a high dose of paralytic, how will you really know if the patient is fully sedated if it's paralyzed? Like, do people think that they would do that?
Say that again.
I'm curious what other people think about, like you suggested, and then using a half dose sedative, like ketamine at half dose that you, as compared to what you would usually use, and using a full dose or higher than usual dose of racuronium, because you won't be able to reassess your patients to know if they're sedated adequately if they are paralyzed.
So I think I agree, once you intubate them, you definitely should start a sedative right away because you're not going to one of the downsides of using rocuronium. I think it really depends on their hemodynamics. I think here obstructive shock, the hemodynamics will tank very quickly. So the idea is potentially not giving too much of taking the surge. I mean, I think a lot of this stems from parts like thinking of conduction. It makes sense physiologically. I don't know if that's
Scott Weingart also calls it rocket.
But I agree that the big thing you have to remember, if you can use rocuronium, which is nothing wrong with using it, but you should be starting a sedative right after intubation. The peri-intubation setting is what the patient's most at risk, even out.
Dr. Willis says that if you use this combination of sedative and paralytic, you should start sedation right after. Next step, intubating a patient with massive PE, pre-oxygenate heavily, avoid the hypoxia, minimize the apnea time. Again, this is probably not a junior intubation. This should be something that goes really quick. Keep the nasal cannula on while you're intubating. Use the technology, and first try success is required in the patient. And then afterwards, how do we ventilate this patient? It's very, very difficult. Generally, pressure should be kept low. Moderate ventilation, PEEP should be minimized, and FiO2 probably should be elevated. Goal is to keep the oxygen high and reduce the CO2, which is very difficult to achieve. That's why sometimes there was the comment that if you are in this situation and you have it available, you should even consider ordering a patient right. Another thing that I thought was interesting is for massive PE patients, there's suggestions of awake intubation. So I've never awake intubated. Anyone in the room has ever intubated? Dr. Bernsheimer, how was that?
I mean, you have to have obviously a cooperative patient, but it's possible to do that. The ones I remember that we were able to do that with were COPD patients. I don't think I've ever awake intubated a massive PE.
So the suggestion is to do it because then you maintain their own catecholamines and you allow the cardiac output sufficiently and the vascular tone. So what I saw recommended is you want to control secretions, so they are giving glycopyrrolate. Then you want to reduce anxiety in the patient, so you have to give them some anxiolytic, ideally not too sedating, and get them into apnea. And then you need to anesthetize, locally anesthetize. So there were some suggestions to give lidocaine in a nebulizer first, then use some viscous lidocaine back of the throat, and then spray some afterwards. And then basically go ahead and position the patient and patient.
Yeah, when I've done it, it usually was with a low dose of benzo, get it from hypertension, benzo, plus lidocaine.
Yeah.
I think the problem is sometimes, I agree that for it to be successful, you need all of that preparation. Sometimes if they're crashing or worried, it's difficult to do. And so I think RSI is the best first pass success. But it's something to consider, man. I think it's that patient that you're thinking is going to crash and have a little bit of time. Because as Annette said, you need all that preparation, kind of the low dose benzo, the anesthetic, really successful otherwise.
If these patients are awake enough to be intubated, they probably don't need to be intubated.
This guy that you had was, I mean, he was pronounced status, he wasn't cooperative, couldn't do it awake.
That's true. Our patient was not.
These patients are too
cooperative.
sick to.
Yeah.
Unfortunately, by the time you're intubating them, they're
Yeah.
Oh, so I'm running out of time, unfortunately. So this is my summary page, but we went through all of it. ECMO, basically just a comment. We don't have ECMO available on it, unfortunately, but very interesting as a bridging for other therapies like give thrombolysis time to work. Also use the other more invasive approaches. To come back to our patient, the ICU course was very brief. He had recurrent PEA arrest, ACLS for 30 minutes, and then the patient was dead. The background, Dr. Z already covered everything. He had the neck mass since January. He had a lot of loss of time in trying to get appointments with COVID coming his way. And he was finally set up to start his treatments. He came to clinic and the autopsy showed a massive thrombi in the RV, IVC, SVC, and subclavian, thrombi in gastric vessels, and extension. Quick summary TPA, systemic thrombolysis is very effective at rapidly improving perfusion compared to anticoagulation alone. In the peri-arrest PE patient, management of thrombolytics can save lives. Benefit of thrombolytics outweigh the risk of ICH, especially in the under 65 patients. Summary of POCUS. In unstable patients, POCUS can help to determine critical interventions. Signs include right ventricular dilatation, systolic dysfunction like the McConnell sign and the D sign, and POCUS can visualize clot in transit in the RV and IVC. Summary pitfalls: do not reflexively give IV fluids for hypertension as it could significantly worsen. Maintain oxygenation, consider other ways like hypertension. Try not to intubate, and have pressors running or push doses ready when some of my sources plus several podcasts. And thank you very much for your attention.